a 70-year-old male diabetic hypertensive and a strong family history with past history of TIS 5 years back and post PTCA status with 2 stents 1 year back for anterior MI comes for follow-up. Apart from medical optimization and lifestyle modification, best strategy for risk reduction would be. So, Chandra, Abhishek is going to go first.
Good evening. So, I think as so, next. So this is a 70-year-old male, but the case we routinely see in our practice. 70-year male, diabetic, hypertensive, strong family history of CAD. The patient had a past history of TIA 5 years back, and then he had an MI 2 years back, underwent angioplasty with 2 stents in LED. And then now after 1 year of 1 year of anterior wall MI and stenting, now the patient has come back to your OPD. Now this is the time when you reconsider and revisit his prescription. Because after 12 months of completion of dual antiplatelet therapy, now you decide whether my patient belongs to a high ischemic risk, high thrombotic risk patient, or a low thrombotic risk patient, whether my patient belongs to a high bleeding risk patient or low bleeding risk patient. So in this patient, we can clearly see, like this is a 70-year-old male with history of TIA, means already the patient had a stroke. History of angioplasty with 2 stents, anterior MI 1 year back, means 2 atherothrombotic events in last 5 years. 1 year back an coronary event and 5 years back a cerebral event, as well as high risk factor like diabetes, dyslipidemia, hypertension on optimal medical management. Now, what should be done for this patient once the patient comes to you? Many times, like earlier, we used to use the term chronic stable angina, which has been revisited and found that there is nothing stable in coronary artery disease. This is a chronic CAD, chronic coronary artery syndrome, and which is characterized by platelet activation and persistent thrombin generation. So many times what happens in a patient with low thrombotic risk, we continue with single antiplatelet therapy if the patient doesn't have high thrombotic risk, and we manage the patient with well. But if the patient has high thrombotic risk patient with due to multiple risk factor which we are going to touch, then is 2 antiplatelets working through the same pathway sufficient, or should we plan for a dual pathway inhibition, one way working on the antiplatelet therapy as well as the second working on the coagulation anticoagulant therapy? So the dual pathway inhibition with rivaroxaban 2.5 mg BID plus aspirin. Now this offers a antagonism of both antiplatelet antagonism of antiplatelets as well as the coagulation pathway. Now we all know what are the high risk patient. If the patient has complex CAD and if the patient has some risk factors like diabetes, recurrent MI on antiplatelet, peripheral artery disease, or some atherothrombotic event in other vascular territory, which can be limb ischemia, can be cerebral vascular event, or CKD with GFR less than 60. So these are the patients with high thrombotic risk, and these are the patients who are having chronic coronary syndrome. And the patients who have acute coronary syndrome, similar patient like complex CAD with either diabetes on treatment, recurrent MI, peripheral artery disease, GFR less than 30, less than 60, or accelerated, rapidly progressive or accelerated CAD or young CAD. Young CAD means age less than 45, or rapidly progressive means 2 event in less than 2 years despite being on antiplatelet therapy. So if the patient has all these risk factors, your patient has high risk category. In this patient, you can see the patient already has CAD with 2 stents, has diabetes, and has a atherothrombotic event in the different territory, which was the cerebral vascular territory. Now, the patients, those who have diabetes, they have a much higher risk of MACE with atherothrombotic disease. In this slide also you can see that rate of MACE in patients with diabetes is much higher compared to the patients who do not have diabetes. COMPASS study, which compared the role of rivaroxaban with aspirin versus aspirin alone versus rivaroxaban 5 mg BID. In a patient with chronic coronary syndrome patient, those who underwent revascularization or managed medically. Now these patients, what was the qualifying criteria? Either if the patient was the patient has a chronic coronary syndrome, either a documented coronary artery disease or peripheral artery disease of stenosis more than 50%, or prior revascularization in terms of either PCI or CABG, or carotid artery stenosis, carotid artery disease, asymptomatic or post carotid artery stenting, or CAD plus ABI less than 0.9, or prior atherothrombotic event. If the age is less than 65, then 2 vascular beds should be involved with at least 2 of the additional risk factors like current smoker, diabetes, GFR less than 60, heart failure, or non-lacunar ischemic stroke in more than 1 month ago. So you see in this patient, our patient has history of prior revascularization, has diabetes, has symptoms plus more than 50% stenosis, and prior event. The MI already happened and there was a stroke also. So COMPASS DM, diabetes arm, it revealed that rivaroxaban 2.5 milligram plus aspirin versus aspirin alone, it has much greater benefit in patients with diabetes. So COMPASS in general also showed in the entire cohort that the rivaroxaban 2.5 milligram plus aspirin was better than aspirin alone, but the benefit was much more substantial in the patients who had diabetes, and the absolute risk reduction for MACE, which was MI, stroke and CV death, was 2.3%, and number needed to treat was just 44. Similarly, the effect of rivaroxaban 2.5 milligram plus aspirin was much, you can see in terms of all-cause mortality and CV, stroke, death, MI, or major acute limb adverse effect. In both the terms, in diabetic patient, the effect of rivaroxaban 2.5 milligram plus aspirin was far better compared to non-diabetic patients. So the entire cohort was benefited, but the effect was far more significant in patients those who had diabetes, like the patient in question. And the NCB, net clinical benefit of rivaroxaban versus vascular dose plus aspirin versus aspirin alone. Again, the net clinical benefit was also higher in patients with diabetes. You can see here, like the diabetes population, the benefit was significantly higher for all these clinical endpoints compared to non-diabetic patients. Now coming to the THEMIS study. The THEMIS study, which studied patients, those who had chronic coronary syndrome. One arm also had the PCI, THEMIS PCI, but the larger THEMIS study, which had 22,000 patients. It studied patients with chronic coronary syndrome, whether to keep these patients on aspirin or keep these patients on aspirin plus ticagrelor. So if you see, the ischemic endpoints were benefited, but the overall mortality was not decreased. You can see in the next slide. You can see all the ischemic endpoints like MI, ischemic stroke is decreased, but CV death there was no difference, and all-cause mortality was no difference. This definitely the ischemic endpoint, because they are giving much more potent antiplatelets compared to aspirin alone, it was decreased, but all-cause mortality and CV death it was not decreased, and the bleeding was higher in these patients. So relative risk reduction proven to different antithrombotic regime. If you see now here, what we are comparing with ticagrelor versus rivaroxaban, the THEMIS is stable, which had CAD with diabetes mellitus. The MACE was decreased by 10%, MI was decreased by 15%, but the ischemic stroke was no significant reduction, CV death no significant reduction, and total death was no significant reduction was seen. So if you add aspirin and clopidogrel, the ischemic stroke, CV death, and total death, all-cause death was not decreased. MI and in general MACE was decreased. However, the bleeding risk was increased by plus 132%. However, the ICH was not significantly increased. Now, if you see COMPASS in general, without entering diabetes, rivaroxaban 2.5 BID plus aspirin, the MACE was decreased significantly. Ischemic stroke was decreased significantly, which our patient already had a previous history of TIA. CV death was decreased significantly, and death was decreased significantly. Bleeding was increased. There was no head-to-head comparison, but bleeding was decreased by plus 70 point. Here, the bleeding was increased by 132% point. Here, MI was not decreased, but in general, overall, the CV death, all-cause death, ischemic stroke, and MACE was significantly reduced. Now, if you see the diabetic subset in this patient, like COMPASS DM, the CAD, stable CAD with diabetes, here again, the MACE was further decreased, the stroke was further decreased, CV death was decreased, all-cause mortality was decreased, the bleeding did not increase significantly. There was no significant difference, reduction in MI, but all other ischemic indicators, and most importantly, the mortality, CV death and all-cause mortality was decreased. Once you add rivaroxaban to aspirin in patients with diabetes and stable CAD post-PCI. So high-risk patients, they benefited maximum with rivaroxaban vascular dose plus aspirin. If you see, if the more than 2 vascular bed was involved, the benefit was more. if the patient had history of heart failure, diabetes, and if you keep on increasing the number of risk factors, the benefit of rivaroxaban keeps increasing. Now, the treatment option, like after 1 year, if you want to continue in your patient, depending on its risk profile and thrombotic profile, if you want to continue, you have 4 options. Clopidogrel, you can continue in the DAPT trial for more than beyond 1 year if your patient has tolerated it well. Prasugrel, in the post-plastic patient, you can continue beyond 1 year. Rivaroxaban, you can start after 1 year and can continue. And ticagrelor, 60 milligram BID, less than the normal dose, beyond 1 year. But in other drugs like clopidogrel, prasugrel, and ticagrelor, antiplatelets, the reduction is there in terms of post-MI patients only. However, in rivaroxaban, you can see there's a reduction in multivessel CAD as well as the patients who have atherothrombotic disease in other vascular territories, peripheral artery disease or cerebral vascular as well. Second, the compass, the benefit persisted despite, irrespective of when the patient had MI. Because even if you see less than 2 years the MI, 2 to 5 years to the, after MI, or more than 5 years after MI, the benefit remained there. The hazard ratio, the confidence interval remained on the benefit side. However, the same thing was not true with ticagrelor, because when the ticagrelor, it was seen that the benefit was maximally for immediately after 2 years of post-acute vascular event. After 2 years, the benefit was not much. The compass primary endpoint prior to PCI, if the PCI was done versus no PCI was done, in both the groups, the benefit was there in terms of reduction of CV death, MI, and stroke. Significant reduction of all-cause death, and the curves start separating early. Suppose if the prior PCI or no history of prior PCI, in both group benefit is there. If the patient underwent PCI early, the benefit starts appearing early in these group of patient. And if you see the study till 10 years, you can find the hazard, the confidence interval remained below 1. So the benefit was persisted even till long duration, even after the PCI or event was done. All-cause mortality also was benefited. However, in ticagrelor Themis PCI, the benefit started disappearing after 2 to 3 years, and the confidence interval crossed the line of confidence interval. So, as I mentioned, in Pegasus study, you can see the maximum reduction was achieved within 2 years of MI. After 2 years, because it was a 3-year study, after 2 years, the benefit was not there. So, this is just to compare what is there in Compass PCI versus Themis PCI. Ticagrelor 90 with aspirin, and here rivaroxaban 25 with aspirin. MACE was decreased in both the groups. All-cause death, rivaroxaban decreased, ticagrelor not decreased. CV mortality, again, rivaroxaban decreased, ticagrelor not decreased. MI, ticagrelor decreased. This is rivaroxaban not decreased, and stroke, both groups decreased. So the mortality reduction, if you see major difference here, the mortality was less. All-cause as well as CV mortality was less. With rivaroxaban 2.5 milligram BID, and mortality benefit was not there. However, MI was lesser, ticagrelor group compared to prasugrel group. So just to cut the long story short, I would put CVD risk does not end in the cath lab, and the event-free survival remains a long-lasting commitment, because when the patient comes after 1 year, 2 year, 3 year, you don't want second atherothrombotic event when the patient is follow-up and taking the medicine properly. So in my patient, I would consider, depending on his risk factor and all, 2.5 milligram rivaroxaban along with aspirin.
Now we invite Dr. Gajendra Dubey for ticagrelor with aspirin combination, his views.
Good evening, respected chairpersons and moderators and dear colleagues. And first of all, I would like to thank Dr. Kamal Sharma sir for this opportunity. After listening to Dr. Abhisheka, I think I'm also a bit convinced that yes, rivaroxaban is slightly better option. But I would like to put some points in favor of ticagrelor. So patient profile is already known. He is a 70-year-old male, diabetic, hypertensive, strong family history, prior history of TIA. He has undergone PTCA with 2 stents just a year back for anti-wall MI. So he comes to us for further advice. So I would like to have some more details like EGFR of the patient, mammogram, past history of bleeding, any smoking history, type and size of stents, completeness of revascularization, whether he is taking ticagrelor or clopidogrel, or he is on single antiplatelet, does he have peripheral arterial disease, what is his ejection fraction, and how well controlled his diabetes is. So this data is required to accurately assess his ischemic risk as well as the bleeding risk. So the question which we should ask ourselves is there a need for long-term ischemic protection post-MI? Because so far aspirin has been the standard of care. It has been shown to reduce outcomes in secondary prevention by the tune of around 19 to 20% relative risk reduction. And the question also is that how long this ischemic risk lasts. So as Dr. Abhishek already told that it is not, the risk persists probably indefinitely. There are several studies like the International REACH registry which studied patients who had ischemic events at baseline. In them the events MACE rate was around 18% at 4 years of follow-up. Similarly, there was a study, Apollo study, which studied post-MI patients in multiple countries, and they found that for next 3 years the risk was close to 20%, that is recurrent MI, stroke or all-cause mortality. Similarly, in placebo arm of Pegasus also the MACE rate was around 15%, that amounts to around 5% per year after MI. The Improve It trial also showed that polyvascular disease patients with diabetes are at very high risk of recurrent events, with event rates reaching up to 50% at 7 years of follow-up. And similarly, complex PCI, we can consider this as complex PCI because it was a STEMI scenario and he has received 2 stents. So complex PCI patients are definitely at much more higher risk of MACE events as compared to those who have undergone relatively simpler PCIs. So if we look at our patient, if we can calculate the DAPT score in this patient, which will help us in deciding whether we should continue DAPT first of all beyond 1 year or not, because none of the guidelines, in all the guidelines, the DAPT extension is given a 2B recommendation. That is, you can decide, can make a decision based on his ischemic versus bleeding risk. So if ischemic risk is very high and bleeding risk is relatively low, then probably it may benefit our patient. So a few values were missing, but I have assumed a few of things. So even after assuming few things, the DAPT score comes out to be 2 points, which qualifies as a relatively high thrombotic risk. And similarly, the precise DAPT score, which tells us about the bleeding risk of patient, it comes out to, if we assume that he had no prior bleeding and his hemogram, etc. is normal, it is around 23, which comes into moderate risk of bleeding. So this patient is likely to benefit from extension of DAPT, and these scores were derived from the DAPT trial. So what are the options? Aspirin, definitely it is to be continued for lifelong. The other option is DAPT with clopidogrel or prasugrel, although there is no large scale data of continuing prasugrel beyond 1 year. Or it can be a P2Y12 monotherapy also, or DAPT with ticagrelor, or rivaroxaban with aspirin or even clopidogrel. So regarding the evidence of long-term DAPT, the DAPT study was one of the largest studies which showed that extension of DAPT in post-PCI patients who have tolerated DAPT for 12 months without any bleeding episodes, it does lead to a significant reduction in their ischemic risk, that is composite of death, MI or stroke at 30 months. Although it comes at the cost of increased rates of bleeding, but it reduces the rates of stent thrombosis significantly and MIs also. Then the main trial on which the evidence for ticagrelor is based was the Pegasus TIMI54 trial. So the Themis trial was frequently quoted in the last lecture, but Themis trial categorically excluded patients who had prior MI or stroke, and it was done basically in stable CAD patients. So the stable CAD patients definitely are at a relatively lower risk. So in them, if the risk is lower, then the benefit from extension of antithrombotic therapy is definitely going to be lower. Pegasus TIMI looked at such type of patients who had history of MI 1 to 3 years prior to enrollment and have at least one additional atherothrombotic risk factor, and they were divided into 3 arms, that is ticagrelor 90 BD, ticagrelor 60 BD, or placebo along with aspirin. The follow-up duration was around 33 months. Primary efficacy endpoint was same, that is composite of death, CV death, MI or stroke. So in this trial, the primary outcome was reduced by almost 16%. There was 16% relative risk reduction in MACE as compared to placebo. And all the endpoints or components of the primary endpoint were significantly reduced. There was a reduction in CV death. So it didn't reach statistical significance, but the number of MIs were statistically significantly reduced and stroke rates too were lower. But the downside of extending DAPT beyond 1 year, the major bleeding rates were higher, although the fatal bleeding and ICH bleeding rates were not significantly different, but it did definitely lead to more chances of bleeding. So the article states that if you treat 10,000 patients for a year with ticagrelor beyond 1 year, 42 events will be prevented with 60 mg dose at the cost of 31 extra bleeds. And as Dr. Abhishek also stated that in patients who have suffered an MI recently, that is within past 2 years, the benefit was greatest. Beyond 2 years, the benefit was not that marked. But the patient in question has suffered an MI a year back, so that probably that is the point why we may consider ticagrelor in this patient. There was another outcome, that was the irreversible harm, which included CV death, MI stroke, ICH and fatal bleeding. So there was significant 14% reduction with 60 mg dose as compared to placebo. And the greatest benefit was seen if there was no interruption in the antiplatelet therapy, the dual antiplatelet therapy. Those who had interruptions less than 30 days were the ones who derived maximum benefit. Similarly, there were several sub-studies of this trial which showed like in patients who had prior MI and PAD. These were sub-studies of the Pegasus trial. There was significant reduction in MACE rates and CV death. Similar benefits were seen in patients who had multivessel disease and patients with diabetes and prior myocardial infarction. THEMIS trial, as I already said, it excluded patients who had prior MIs. It included stable patients. And the original trial was neutral. It didn't show any significant benefit with ticagrelor. Although THEMIS PCI trial did show some benefit, the event rates were lower and bleeding rates were significantly higher. But overall, there was some net clinical benefit. But because this was a study which was concluded from a trial whose primary outcome itself was neutral, so it is just a hypothesis generating, I would say, and not a conclusive evidence. And coming to rivaroxaban, so the idea is that clinical experience with rivaroxaban in such a setting is still limited. How many of us would put this patient on rivaroxaban? I think most of us won't consider starting rivaroxaban, because the evidence base with rivaroxaban for such patients is still building, probably, I would say. Ticagrelor has been studied in more than 20 randomized controlled trials, and it has established its efficacy and safety in such patients. So the patient population in both the trials were different, so it may not be fair to compare them with each other, although the given patient resembles more like a Pegasus trial population. So I would say that ticagrelor may be the preferred option, because in COMPASS trial, less than 2/3 of patients had a prior MI, only 62%, and those who had MI, 79% were more than 2 years from their prior MI. Mean time from MI to presentation or enrollment in this trial was 7.1 years. So both trials did show benefits, and but our patient more closely resembles the Pegasus trial patient, so probably ticagrelor seems to be the more logical option. Regarding bleeding rates, rivaroxaban also showed significantly higher rates of major bleeding as compared to placebo, and there were more GI bleeds with use of rivaroxaban as compared to placebo. So if we come to a patient selection algorithm, this patient is post PCI, post MI, he has more than 2 risk factors, and these type of patients are more likely to benefit from extension of dual antiplatelet therapy. So those who have multiple risk factors like multivessel disease, diabetes, peripheral arterial disease, CKD, multiple MIs, they are at higher risk, and if they are at higher risk, then extension of DAPT is more beneficial. So if we go to the second step, first of all, we should look at our ischemic risk and then assess the bleeding risk also. If the patient is low bleeding risk, that is very important, then only we should consider extension of DAPT or even addition of rivaroxaban also, I would say. And patients who were low bleeding risk and had more than 2 ischemic risk factors, ticagrelor 60 mg BD for 3 years showed 34% relative risk reduction in CV mortality, 21% relative risk reduction in CV death, MI or stroke. All the evidence, the right choice for the patient, I mean, according to ticagrelor, or may consider continuing also. These are the two options. I think the patient is probably likely to benefit in terms of ischemic outcomes with both the therapies. So to conclude, I would say that ischemic best of DAPT, novel oral anticoagulants, they cut down ischemic risk over and above aspirin, but bleeding episodes are not. There was a paper in JAG which said that patients, post-PCI patients who were followed up for 5 years, the bleeding risk was as high as 20%. And morbidity and mortality rates with bleeding episodes reach to the levels of those with recurrent ACS episodes. So bleeding episodes are not innocuous, or they are not negligible. Bleeding episodes are to be taken seriously. So we should balance the ischemic versus bleeding risk and provide the best therapy to our patient. Regular assessment is also important, because someone who is not a high bleeding risk currently may become high bleeding risk over a period of time. Someone who has tolerated DAPT for 1 year does not mean that he will not bleed with DAPT in the next year. Thank you.
Thank you to both speakers, Abhishek and Gajen, for putting their points. So both are equally valid. Still questions. My preference, one thing is that if you are using ticagrelor, then you can use it alone. So you are safe from the side effects of the aspirin, which is very common with the aspirin GI bleeding. That is my personal view regarding this, but not necessary.
I agree, very well represented. I mean, this is a very day-to-day scenario for any cardiologist practicing. So both the points very well highlighted, and the case seems to be tilting both sides once in a while. As a patient has a history of TIA, so CV risk also increases. So that aspect, it warrants 3 years or 3 years at least of ticagrelor. But then, of course, as per the COMPASS trial, if CV risk is there, for that reduction, rivaroxaban is also appropriate. So it's a kind of a win-win situation for both. So I guess Kamal sir can put more light on it.
So I think points are valid. I think the deliberate intent was to keep a case where both therapies can work. If you're not looking at a high CV risk, I think a good patient for giving rivaroxaban compared to ticagrelor would be somebody with a polyvasculopath. More number of beds are diseased, better is to give rivaroxaban. If you're looking only in a coronary bed, non-diabetic, low CV risk group, and you're only looking, like you've put a long stent, multiple stent, and especially STMI subgroup, because the data was primarily from the STMI subgroup. And also when you're looking at other subgroup where you want to take off aspirin and continue only ticagrelor, that's one subgroup where you can think of that as a therapy. But if somebody had a stroke or a TIA, that strongly tilts the balance in favor of rivaroxaban along with aspirin. That's my take. And we know that from the data of definite and possible stent thrombosis versus other therapies. So that's the quiz. 60 milligrams can be continued, high CV risk post-PT. How long? How long? That is the other question. How long? So once you have, can we have the quiz? How long? Can you give it for 1 year? Can you give it for 2 years? How can you give it for 4, 5? How many years? Lifelong? That's the quiz for today, for this bout. Any other points or comments or rebuttal that anybody has on the panel? Any other points?
One thing that was coming to my mind is that neurologists also use ticagrelor, and it has also good data for preventive ability as far as stroke is concerned. So that can also be considered?
Ticagrelor has been studied in 2 randomized trials of stroke also, the Socrates and Thiel's trial. So Socrates did not show much benefit where ticagrelor alone was used, but in combination with aspirin, it did reduce the chances of recurrent TIA or stroke, disabling stroke also. So recommendation wise, I mean, it was probably said that for you can continue DAPT for a month or 2 after high risk TIA or mild to moderate stroke. So ticagrelor does have some evidence base in that part.
So
also.
ticagrelor was used in that subgroup of patients with obstructive carotids and already established stroke without evidence of coronary artery disease. So that really is interesting actually. If in that subgroup of patients there was no, or patients had undergone a PCI or something, these patients were having non-intervened type of coronary or no coronary involvement, both kind of patients, but they were patients who already had a stroke or a TIA, and they're studied compared to aspirin alone, aspirin plus ticagrelor. And ticagrelor showed reduced incidence of recurrence of stroke. So we now know that it works as A, it works as B. Whether it works A plus B, we don't have a trial for ticagrelor. But we do have that trial for rivaroxaban. But yes, again, as I said, if the patient is high bleeding, as what Dr. Gajendra was showing, then Tica would actually win. You get lesser bleeds compared to what you had number of bleeds in Compass. So more the bleed, Tica would have, less the bleeds, rivaroxaban will win. More the beds of disease, rivaroxaban is better. Transseptal, STMIs, then only ticagrelor. NSTMIs and stable CADs, do we have data? Probably not so strong. Pegasus was very strong for transmural MIs, not for NST or stable CAD or ACS. So that was the question. Can we have the question? Any other comments?
In this particular patient who has strong family history and recurrent ischemic events, when should we consider clopidogrel resistance?
Clopidogrel resistance is something that you would suspect if you have a good patent stent and you've done an IVUS or done a platelet aggregometry and it shows that the platelets are not getting inhibited. I think the reason that he's getting recurrent events in multiple places is more not to do a problem on clopidogrel. For doctor, it is easy to push ki aapki dawai se ho gaya, but usually it's the patient, not the medicine, because you blame patient, then patient will hit you back that it's because of you. So most of the times we say because the drug did not work, but that's not the case. 9 is the right answer, and 3 is the right answer. 9 people got it right. Lifelong, we don't know, because the data, it may work, but Compass had patients on rivaroxaban up to 10 years, while for Pegasus Timmy, it was only for 3 years. So these are the people who got it right. I think Meghal was the one who got, or was it Charmi? Have you got prize? So Charmi and Meghal, both of you can come. Last quiz also we'll give it to you. Both of you, Charmi and Meghal, both got this one right. So I request chairpersons to give prizes to the winners and come for a photograph. Next.